Hello. Today we are going to talk about antipsychotics, medications, and the other two names that we may see in the literature or in the books, neuroleptics or major tranquilizers are other two names for drugs that are used for as antipsychotics. And from their name, antipsychotics, that means drugs that treat. So to start with, we need to understand some definitions, and the first one is psychosis. So what is psychosis? Psychosis is a mental state involving a detachment from the reality, which means that the patient is not responding in a normal way to the environmental stimuli. There is a change in the personality and abnormal thoughts in the patient, as well as in the past. Other names for psychosis may be in the public, such as madness, or in Arabic al-junun, or some people think it's a supernatural power that controls the patient's behavior. Usually the diagnosis of psychosis comes by exclusion, which means that we look for any underlying conditions, maybe medical, diseases or anything else, and if nothing there, so we think about psychosis as a disease. To continue about the definition, some definitions that are related to psychosis, we have to differentiate between three different definitions: delusions, hallucination, and illusion. Please think about differences for a minute. And the main difference is that delusion is abnormal thought without evidence. A patient may believe that there is something or conspiracy theory or anything happening in the world, but he has no proof for that. So that is a delusion. The patient is believing in, for example, attack of aliens on our planet, but he never saw that. No reports, scientific reports or authentic resource said there is an attack. So that's a delusion, for example. Hallucination is, on the other hand, is that the patient start to maybe have a sensational problem where he has to see or smell or speak with things around him. He see things that we normal people don't see. He hear voices or sounds that we didn't see. Patients say like, "Oh, I was talking to some kind of angel, or I was talking to a devil or something like that, and he's the only one who's doing it." Or he sees things around him, people around him or her, and nobody else can see them, so that is a hallucination. Illusion, on the other hand, both normal people and people with psychosis, they look at the same objects, but they have the perception differently compared to normal people. So, for example, if I look at a book, I say it's a book, everybody says it's a book. The patient with psychosis says, no, it's not a book, it's a machine that controls, for example, the nuclear bomb in the world. So that is illusion. So patients with psychosis usually suffer from either delusion or hallucination or illusion or a combination of many of these. As we mentioned earlier, uh, psychosis as a disease is diagnosed by exclusion, which means if you find somebody who has some symptoms of delusions or hallucinations, you may start thinking about underlying cause. And some of these causes are genetics, could be. Um, they found some people in some families, they have more trend than other families, so that's why there's a question mark about it. Some delusion or hallucination could be a normal thing. Maybe people who, for example, wake up from midnight, they didn't have enough sleep, or sleepy people after sleep deprivation. They may have some signs of delusion and hallucination. Environmental is a big factor, such as stress. People who have stress and start to behave um, look like patients with psychosis. We cannot say that they are psychotic. This is environmental stress. Medical conditions is the most common factor for delusion and hallucination. Some examples are people with Alzheimer's disease, brain tumors that they present in some areas in the brain, infectious diseases such as viral encephalitis, meningitis, also electrolyte imbalance. All of these can produce psychotic-like behaviors as well as fetal infections. Another big factor of psychotic-like behavior may be induced by some medications. Examples of these ones: people who are under the influence of alcohol, or people who smoke cannabinoids. They may start to speak or they have delirium, or speak with no sense logic. This is an example of drug-induced psychosis. Cocaine, amphetamine, and MDMA, they are stimulants. We're going to talk about them in a lecture about the drugs of abuse. These could lead also to psychotic-like behaviors. Another big example is kappa opioid receptor agonists. Kappa opioid is one subtype of opioid receptors, and they found that the agonists to these receptors may produce psychotic-like behaviors. We see these kappa agonists in some kind of mushrooms that may, if a person eat that mushroom in the wild, so it may produce psychotic-like behavior. Another big example is NMDA antagonists, such as ketamine. Ketamine is a medically used drug, and they found that patients who are under the influence of ketamine may produce psychotic-like behaviors. The other drug with the same family is fentanyl. So what are the signs and symptoms of psychosis? Now, for the purpose, for the future management or treatment of psychosis, they classified the symptoms to positive symptoms and negative symptoms. Positive symptoms means that the patient who are psychotic or schizophrenic, they behave, they do things, they behave things that normal people should not do, which is opposite to the negative, where the patients and the psychotic patients, they don't do things that normal people should do. Example of positive symptoms include, of course, hallucination and delusions, thoughts disorders, as well as abnormal behaviors. The patient may be agitated because he sees things, so he wanna run away from them, or hear things that he wanna follow, or something like that. Agitation, aggression, hostility. All of this is examples of behaviors that classified under positive symptoms. Negative symptoms, psychosis, such as people who are withdrawn from the social contact. For example, if the patient is in a lecture, for example, and he has psychosis, so he is not following the teacher, he's just thinking, he's looking at the sky. So this is not normal for individual. The individual in the social environment, he communicate, speak with the people around them, or if he's in the lecture, he listen to the professor and write notes, for example. So this is a negative signs of psychosis. Flattening informational responses. The patient is not responding to, for example, jokes or funny things or sad things, so there's no facial expressions, as well as decreased attention and memory. This all may lead to anxiety and depression, and this is eventually will lead to suicide in these patients. It's very common, this suicide attempts in patients with psychosis.
Now, to, to start with talking about treatments and management, we should know the physiological basis or the pathogenesis of psychosis or schizophrenia. Now, it's it's not 100% confirmed the physiological reasons or pathophysiology of psychosis, but most theories accepting things that is related to the problem in the brain, as we'll see in the next few slides. Some other people think it may have something to do with again with supernatural powers. So the patient will decide, or the patient, if he is believing in these things, of course he will go to the places where he can treat this supernatural power. But in medicine, this is a disease, and there is some treatments and management drugs that is used in the management of psychosis. So that's what we today. In the past, before the discovery of good medications, people thought that this is due to a problem in the brain. So they used in the past something called electroconvulsive therapy, where they induce a high current electricity into the brain of the patient, and they think that will reset all the neurons back to the normal individuals. But this gives an idea that even in the past they thought it is something in the brain. Some other approaches in the past used some, for example, giving the patient insulin to produce hypoglycemia, and hypoglycemia will induce seizures in the patient, and the seizures themselves will reset the electricity or the wiring of the brain. That's what they think in the past. Even like more early approaches were asking, doing the patient something called bloodletting, where they just make an incision and they make extra blood to go. But all these approaches were used in the past to treat patients who have symptoms of psychosis or hallucination. But that indicates that, yes, there is a physiological basis, and they used physiological approaches to treat diseases or to treat the signs and symptoms of patients. So what is the most accepted theory of psychosis? The theory is now based mainly in dopamine hypothesis. So what is dopamine hypothesis? Is that in the brain, normally we have a balance between many neurotransmitters. The two biggest examples are dopamine agonists and dopamine neurotransmitter and the glutamate neurotransmitter. There is a balance between them.
But before we proceed with the dopamine hypothesis, let's talk about dopamine as a neurotransmitter and its receptors. So dopamine is one example of catecholamine neurotransmitter. It's the precursor of norepinephrine and epinephrine. And in the brain, we have three major projections in our brain where dopamine is released as a neurotransmitter. This is the structure of dopamine, and the three projections are: the first one is the neurons where cell bodies located in substantia nigra, where they send their axons to the basal ganglia, to the striatum, and this dopamine release is very important in the control of movement. And the diseases such as Parkinson's disease, there's a problem in this projection from substantia nigra to basal ganglia. Ventral tegmental area also has some dopaminergic neurons where they send their axons toward the mesolimbic pathway. That pathway is called mesolimbic because it goes from the ventral tegmental area, which is in the midbrain. That's where meso comes from, and toward nucleus accumbens, which is in the in the area of the forebrain, and it's part of the limbic system. So it's mesolimbic pathway. The release of dopamine in this pathway is very essential for the reward and cognition, and this pathway is very important in the drugs of abuse, and other natural rewards that the patient feel excited or happy about. The third projection is from arcuate nucleus toward the pituitary gland, and the release of dopamine there inhibits the secretion of prolactin from the pituitary gland. And we mention these projections because, as we will see, drugs that interfere with the dopamine release, either agonist or antagonist, it means that it will interfere with these projections, and that's where side effects come from. Dopamine binds to five subtypes of receptors, but because there are similarities between some of these subtypes, so they classify them to two major subtypes. The first one, which is under D1, which includes the subtype 1 and subtype 5, it is a G protein coupled receptor for dopamine, and it is associated with the G excitatory neurotransmitter, and that's why it's GS. As well as we have the dopamine receptors 2, 3, and 4. They are categorized under D2 receptors, and they are inhibitory, as well as they are G protein coupled receptors. So both of them are metabotropic, but one of them is excitatory, which is D1, and D2 is inhibitory. And these figures show the differences between D1 and D2. We can see that both of them are G protein coupled receptors, which is a 7 transmembrane protein, and they are associated with G protein intracellularly, but one of them, which is the dopamine receptors, are associated with the excitatory G protein. However, the D2 is inhibitory, G inhibitory, which inhibits the post neurons. So, going back to the dopamine hypothesis, in psychosis, the major problem is that we have imbalance between the levels of dopamine and the glutamate, and that's why dopamine is considered too much in the brain compared to the glutamate, and that is the accepted theory behind the signs and symptoms of psychosis. However, some evidences support this hypothesis and some other observations against this hypothesis. So, pros and cons against this hypothesis. So examples of pros of this hypothesis is that the dopamine receptor agonists, so drugs that increase the action of dopamine, actually produce psychotic-like behaviors or psychotic-like effects. Examples of these medications, amphetamine and bromocriptine, they increase the levels of dopamine in the synapses, and they produce some sort of psychotic-like behaviors. Also, drugs that block the NMDA, as we mentioned earlier, such as ketamine and phencyclidine, they decrease glutamate, so that produce imbalance between dopamine and glutamate, and for that reason, they thought that yes, this theory may be acceptable. Also, antipsychotics, drugs that we're going to talk about soon, are actually dopamine antagonists, and these drugs are the drugs that produce the most efficacious compared to other classes of medications. I'm not going to say they are very effective, but at least in comparison to other classes or other drugs that target different receptors, these are the most common drugs that are prescribed to produce a good outcome in the patients. Examples of these medications, as we will see in the next few slides, clozapine and olanzapine. As we mentioned, some evidences or observations are against this theory. Examples of these observations is that antipsychotics are not always effective. Some medications, some patients are responding very well, but other patients does not. So we don't have a good explanation for that, but this is against the theory of dopamine hypothesis. Therapeutic effect, even in patients are responding, it's not acute. So that doesn't mean like next day the patient is feeling very good. Usually the effect is delayed, and the um, the effect is delayed, and it lasts for some weeks or sometimes months. And finally, we have some medications that approved by the FDA for the treatment of psychosis. They are not specifically target dopamine or glutamate. They can target the serotonin, and some of them actually only target serotonin without any effect of dopamine. So why they are effective in treating psychosis? So again, this is again high dopamine hypothesis, and it does not mean that other medications may not be useful. So, but these are now currently dopamine antagonists as the most common prescribed medications for. Now, what are the principles of using antipsychotics? Again, the exact physiology is not well understood. Many people do respond, and partially, and very few respond completely, and some patients does not respond at all. As we mentioned, therapeutic effects may be delayed for several weeks or months, and all drug classes have a significant side effects. And for that reason, so medications, we don't like to combine medications together. We like to start with first medication. If it's not very effective and we want to switch to the other one, so we usually stop the first medication and then we give the other medication for patients. Most medications, if not all, actually are effective against positive symptoms, the symptoms we talked about earlier. Almost all of them, except one, are not effective in negative symptoms. And because they have serious side effects, we use the minimum effective dose, and we start to increase the dose to achieve either a good therapeutic outcome, or the patient will suffer from side effects that we cannot increase or continue the drug. What are these side effects for antipsychotics? Hyperprolactinemia, and this should make sense to you by now because there is a dopaminergic projection from the arcuate nucleus toward the pituitary gland, and the too much dopamine will decrease prolactin. So if you block dopamine, that means prolactin will increase, and that produces hyperprolactinemia, and that will produce galacturia in females and gynecomastia in males. A very essential side effect and very common is sexual dysfunction, and that is because of the loss of libido. The patient is not feeling or does not have the desire to have sex with his partner. There is another symptom called neuroleptic malignant syndrome. This is a serious problem where the patient will suffer from rigidity in the skeletal muscles, maybe hyperthermia, and this is a medical emergency. We have to stop the medication as well as going to the emergency room, and that they may prescribe some medications. And I want you to actually to look for what is the best treatment for neuroleptic malignant syndrome for patients, and maybe you look further into the signs and symptoms of neuroleptic malignant syndrome. Tardive dyskinesia, which is involuntary movement of skeletal muscles, especially the fine and small skeletal muscles, such as the muscles of the fingers, muscles of the lips, and the tongue. So these are skeletal muscles, and the patient under these medications they start to has uncontrolled movement of these skeletal muscles. the patient starts opening his mouth or protruding his tongue or playing with his lips or her lips. So these are the tardive dyskinesia. They may produce sedation, hyperglycemia, and diabetes. This is hyperglycemia and diabetes because it is a serious problem with these medications. It's very common, and that's why the patient should be monitored for blood glucose. And actually, some medications are black boxed for the patients to highlight the importance of this side effects in these drugs, as well as they may produce weight gain. And if you notice that I have sedation and weight gain under question mark, because this is maybe due to their effect on histamine. They are also histamine antagonists, so they may produce these effects by working on histamine. Now, all antipsychotics, regarding of their classification, typical or atypical, as we'll see in the next slide, they produce all these side effects. However, typical antipsychotics, they tend to have the side effects in the first 5 side effects mentioned in this slide, and atypical antipsychotics, they tend to produce side effects for the last 3 side effects. However, all of the antipsychotics may produce any of the presented side effects. So as I just said, typical and atypical, or they can call first generation and second generation. And when you see 2 generations, you just think about that the second generation maybe has either a better therapeutic effect on patients, or they have less side effects. So first generation are discovered earlier compared to the newer generation or the second generation. Effectiveness, the atypical maybe better therapeutic outcome compared to the typical. That's why there is a question mark. The mechanism of action, typical antipsychotics, the first generation, are mainly dopamine, specifically dopamine D2 receptor antagonists. But in the atypical antipsychotics, they combine between the dopamine antagonist as well as the serotonin receptor antagonist, and the subtype specifically is the 5-HT3C serotonin receptor antagonists. For the side effects, for the extrapyramidal side effects, it was too much for the drugs in the typical antipsychotics. However, it was a little bit. They still can produce it, but it's less than first generation for the atypical antipsychotics.
Okay, now let's talk about the specific medications under each class. We have typical and atypical. The examples for the typical antipsychotics are chlorpromazine and haloperidol. Chlorpromazine is the first drug that was discovered and used as dopamine antagonist in patients suffer from psychosis. Atypical antipsychotics include clozapine, olanzapine, risperidone, and ziprasidone, and aripiprazole, and there are many medications under this class. Clozapine is considered the best drug among all these medications, but please put the clozapine the best as under 2 exclamation marks or parentheses, because again we think that it is the best, so it's reserved for refractory periods. However, this drug found it decreases the risk of suicide in these patients, but the major side effect for this drug specifically is agranulocytosis. For that reason, the patient has to be monitored really closely after the starting clozapine treatment to avoid the serious agranulocytosis happening in these patients. Other medications as olanzapine, risperidone, on the other side, they are less effective than clozapine, um, but in general, this class atypical, they thought that it is good or better than the typical antipsychotics. Typical antipsychotics, such as chlorpromazine, it is the first neuroleptic or the first antipsychotic to be used and discovered. It may produce sedation because it has a very good anticholinergic and antihistamine antihistamine side effects, as well as has anticholinergic activity. Haloperidol, although it is in the class antipsychotics, it's used the drug of choice in patients with agitation, especially patients at their end stage of cancer, where they have uncontrolled agitation and hallucination. So maybe haloperidol is drug of choice. It can be given orally as well as injectable forms, and it is the drug of choice in many conditions of nausea and vomiting, especially after chemotherapy induction in cancer patients. As well as haloperidol is a drug of choice to as an antagonist for patients who are under the influence of some of the abused medications such as amphetamine and LSD medications. Aripiprazole, there is something specific about aripiprazole compared to others, that besides it has a serotonergic antagonist and D2 antagonist, it is a partial agonist also at D2 in the presynaptic receptors. So presynaptically, the presence of dopamine receptors, the presence of dopamine receptors when they are activated presynaptically, they will produce a feedback inhibition of the release of more dopamine to the synapse. So aripiprazole goes and binds to these presynaptic receptors. So after it was dopamine, if it's released presynaptically in the synapse, it binds to the postsynaptic and the presynaptic receptors. Binding to the presynaptic receptors will produce feedback inhibition of the release of further dopamine. So aripiprazole goes and binds to these receptors and activate them to mimic the action of dopamine in the presynaptic receptors, and that will lead to the decrease of release of dopamine from the presynaptic to the postsynaptic receptors, which eventually decrease the effect of dopamine in general in the system. Other antipsychotics, which has a specific slide, I would call it it's because it's different from the typical and atypical antipsychotics, which is a very new medications. It's a pimavanserin. It's very new. It was approved for psychosis in 2016. It is used mainly for a specific kind of psychosis, which is the Parkinson-induced psychosis. It has no dopaminergic activity. It only activates, or let's say it only targets the serotonin receptors. It works there as inverse agonist. Inverse agonist is an example of an antagonist where it does not affect the constitutional activity of the receptor. Which is different than typical and atypical, that it has nothing to do with dopamine receptors, either D1 or D2. It is a very expensive medication, and as I mentioned, it's only approved for the Parkinson's disease psychosis. Um, the good thing about antipsychotics that they are not only indicated for patients with psychosis. Some other diseases such as anxiety disorders, autism, Huntington disease, and the biggest example is antiemetics, or as antidote for some medication overdose or drug of abuse overdose, as we mentioned earlier. These medications can be used in these conditions. Some clinical notes about antipsychotics. Uh, Almost all of them are effective against positive symptoms, and they don't improve negative symptoms in the same speed as they improve the positive symptoms in patients. The smoking increased the metabolism of clozapine. So if the patient is in the building, in the hospital, the patient with psychosis hospital, and we control smoking, and we adjust the clozapine levels to be therapeutic. So they found that if the patient is released from the hospital and the patient, for example, starts smoking, that may affect the levels of clozapine. Smoking will increase the degradation of clozapine, and that means that the drug is not effective anymore because of the smoking, and that's why we have to adjust the clozapine levels depending on the situation of the smoking condition of the patient. When we change the medication, these drugs have a lot of side effects. We don't like to combine them together, so we start to decrease the dose of one drug, and then we start to increase the dose of the other drug. We don't like to give two full doses of two different medications, because that will enhance the side effects of these medications together. As maybe I mentioned briefly, we have injectable forms, especially for haloperidol. These injectable forms are indicated in patients who are not compliant, that we don't think they are taking the pills because they think this may, they are patients under the influence of a disease. So they have their own thoughts about the pills and the conspiracy about these pills. So if we think the patient is not compliant, so maybe we think about non-compliant, we think about giving injectable forms, as well as in patients with mania or agitation that we cannot control to take the medication, we give injectable form, and that's the indication of these forms of medication. In general, these medications are safe during pregnancy. Um, they they don't found they have teratogenic effects, so they are classified under mostly under C, category C, or category B under the American system of classifying drugs for pregnancy. And I would like to thank you, and I hope you will have enjoyed the studying the lecture from this presentation or from the book. And good luck. Thank you.